Okay, let's unpack this. Welcome back to the deep dive. Today we're doing a really foundational review in reproductive medicine, pulling from the source material Ovarian Reserve, current trends and applications. And this deep dive is absolutely essential. We've really designed it to be a masterclass for you if you're a medical learner, young professional in OB/GYN, or even a specialist just looking to clarify some of the latest thinking. So our mission today is, well, it's pretty comprehensive.
It is. We're going to start with the core definition of ovarian reserve, or OR.
Right, then explore the underlying physiology, which is honestly, it's pretty dramatic.
It is. Then we'll analyze the testing methodologies, the surrogate markers we use, and then most importantly, translate all that into actionable clinical strategies.
Okay, so let's start at the very beginning. What is the standard definition of OR?
So the core concept, the one widely accepted by the American Society for Reproductive Medicine, defines OR by the total ovarian follicle pool.
And that includes everything.
Everything. It covers both that huge dormant pool of primordial follicles and also the smaller group of follicles that are actively growing at any given time. It's a measure of a woman's total remaining reproductive potential.
It feels so fundamental now, but this is actually a pretty young concept in medicine, isn't it?
Oh, very young. It really only exploded into clinical focus in the late 1980s.
Which is right around the dawn of effective IVF.
Exactly. That's not an accident. As soon as assisted reproduction technology, or RT, became viable, clinicians had this urgent need to predict who would respond to stimulation. And the research has just grown exponentially ever since then.
Okay, here's where it gets really interesting for me. The sheer scale of the follicle story over a woman's life. It's not just a gradual decline.
No, it's more like a biological collapse. It's truly the defining numbers story of female reproductive life.
So walk us through those numbers.
Okay, so consider this. The primordial germ cells, PGCs, they reach their absolute lifetime peak, and we're talking about a staggering 7 million cells at around 20 weeks of gestation.
7 million. Before birth.
Before birth. And from that mid-gestational peak, the decline is just... it's relentless.
So what does that look like?
Well, that number immediately plummets to roughly 2 million at birth. It slows down a lot during childhood, but by the time of puberty, we're already down to about 400,000.
So that's still a big number, but it's a huge drop from 7 million.
It's a huge drop. And the depletion continues through the reproductive years until the count hits a really critical number, about 25,000, right around age 38.
And why is that 25,000 number so important?
Because it's the inflection point. It signals the exact moment where the pace of follicle loss dramatically accelerates.
So if you're counseling a patient who is, say, 37, knowing this changes everything.
It changes everything. Before that point, the loss is more or less linear. After that threshold, the loss becomes exponential. You shift from counseling, you have time, to the window of optimal response is closing, and it's closing fast.
And that accelerated decline just keeps going.
It does. Right until only about 1,000 follicles remain at menopause, which is typically around age 50 or 51.
Now, for centuries, we've held this biological dogma that women are born with all the eggs they'll ever have.
Right, that comes from Waldeyer, all the way back in 1870. The idea that oogogenesis, making new eggs, just stops shortly after birth. And every medical professional learns this.
But science is now starting to challenge that.
Precisely. There's emerging evidence, and I should stress it's still highly controversial, that supports the possibility of what's called postnatal neo-oogogenesis.
Meaning new eggs being made after birth.
Exactly. The idea is that they might come from germline stem cells found in the ovary, or maybe even from bone marrow. If this is ever validated, it would completely change reproductive medicine.
We'd shift from just optimizing what's left to potentially restoring the supply.
That's the dream. It would be a total paradigm shift.
Before we get to testing, there's one more biological detail that always gets me, the timeline. From a dormant follicle to one that's ready to ovulate, how long does that actually take?
It's an incredible marathon. The full progression from a dormant primordial follicle through all the stages, primary, secondary, and finally to a preovulatory follicle, takes approximately 1 year.
A full year.
A year-long maturation process for a single egg. It's humbling.
So we can't just count those 25,000 primordial follicles directly. We have to rely on proxies, on surrogate markers.
And that's the core principle every learner has to internalize. Right now, no test can directly measure the true ovarian reserve. Everything we use is a surrogate.
And there's a critical distinction to be made here, right?
The most critical one. These markers predict oocyte quantity, how many eggs might be retrieved. But age. Age remains the single best predictor of oocyte quality.
Okay, let's break down the big three markers, starting with the one that's become dominant, AMH.
Right. Anti-Müllerian hormone, or AMH. It's secreted exclusively by the granulosa cells of the small, growing follicles, specifically those between 4 and 6 millimeters.
And its main advantage is its stability.
Yes, that's its key feature. It has minimal fluctuation throughout the menstrual cycle, unlike, say, FSH. This makes it a really robust screening tool for declining OR.
But it's not perfect. The big issue is the variability between different lab tests, the different assays.
That's its single biggest clinical limitation. The different commercial kits, the IoT, Gen 3, Alexis, they can all produce significantly different results from the same blood sample.
So how do you handle that in practice if a patient brings you results from another clinic?
You have to be incredibly cautious. It's why there's a huge international effort to create a universal standard. But until then, you have to know which assay was used, and ideally you establish a baseline and track any changes using the exact same assay over time.
Okay, let's move to the second pillar of testing, the antral follicle count.
The Antral Follicle Count, or AFC, is a simple ultrasound measurement. You sum up the small antral follicles, 2 to 10 millimeters, in both ovaries during the early follicular phase.
And this is considered a powerful marker.
Very powerful. Studies have shown a very high correlation between what you can see on the screen, the AFC, and the size of the invisible primordial follicle pool underneath. So it's great at predicting both poor responders and, just as importantly, exaggerated responders.
Which helps you avoid ovarian hyperstimulation syndrome.
Exactly. It's a critical safety tool.
But like you said, it's an ultrasound, so it's completely dependent on the operator's skill and the quality of the machine.
That is the absolute critique, yes.
Yeah.
Unlike a blood draw for AMH, it is inherently variable. It demands precision. If you get an unusually low AFC in a young patient, you always have to consider that it might just be a technical error.
Which is probably a big reason why AMH has become so popular for general screening.
I think so, yes. It's more standardized in that sense.
Okay, finally, the oldest test in the book, FSH.
Follicle stimulating hormone. It's an indirect marker. As the OR declines, the ovaries produce less estrogen and inhibin B, so the pituitary gland sends out more FSH to try and get a response.
The brain is shouting at the ovaries.
That's a great way to put it. But the big limitation is its high cycle-to-cycle variability. A single high reading isn't very reliable. And even worse, high estrogen levels can actually push the FSH down, masking true diminished ovarian reserve.
So it seems like the consensus is moving away from some of these older, more complex tests.
Definitely. Dynamic tests like the clomiphene citrate challenge test, or CCCT, have largely been abandoned.
Why is that?
It's a combination of things. They're complex for the patient, they're more expensive, and crucially, they just didn't offer any better predictive power than the simple static tests like AMH and AFC. They just weren't worth the trouble.
Okay, so for the medical learners listening, it's really important to get the terminology right here. Let's distinguish between a few key conditions.
Absolutely vital. First, you have diminished ovarian reserve, or DOR. This just means reduced fecundity or a reduced response to stimulation. The Bologna consensus gives us clear criteria: an AFC less than 5 to 7 or an AMH less than about 0.5 to 1.1.
And that's different from poor ovarian response.
Right. POR is a term that strictly refers to what happens during an IVF cycle, a low number of eggs retrieved. And then there's premature ovarian insufficiency, or POI.
Which is much more severe.
Much more. This is the near complete loss of ovarian activity before the age of 40. It's characterized by very high FSH levels, over 25 on 2 separate occasions.
And POI isn't just a fertility diagnosis. It has serious long-term health implications.
100%. That prolonged estrogen deficiency puts women at a much higher risk for long-term morbidities, especially osteoporosis, and very critically, increased cardiovascular risk and mortality.
So let's apply these markers to a clinical paradox. Polycystic Ovarian Syndrome, PCOS, is basically the opposite of DOR.
Exactly, and the markers reflect that perfectly. Women with PCOS have a dramatic 2 to 4-fold increase in their serum AMH levels.
And what's the physiology behind that?
The thinking is that these extremely high AMH levels actually lower the follicle sensitivity to FSH. So you get this stockpiling effect where follicles are recruited, but then they just stall out at that small antral stage and fail to ovulate.
So what's the practical value of knowing that AMH is going to be so high in a PCOS patient before you even start treatment?
It's incredibly valuable for safety. For instance, we know that an AMH level over about 10 nanograms per milliliter in a woman with PCOS predicts a nearly 0% chance of a good response to standard treatments.
So it tells you right away you need a different, more cautious protocol.
Immediately. You need a specialized protocol to prevent the very high risk of OHSS that comes with that massive follicle pool.
Let's turn to iatrogenic damage we cause through medical treatment, specifically surgery.
When it comes to surgery, the consistent concern is the excision of endometriomas.
The so-called chocolate cysts.
Right. The data is very clear that surgically removing them causes a statistically significant and, importantly, a sustained fall in serum AMH levels. We're talking about a 25% reduction.
And that's because you're inevitably removing some healthy ovarian tissue along with the cyst wall.
Precisely. You're damaging the stroma where the primordial follicles live.
Yeah.
And that's a much more severe and permanent impact than you see with the removal of other types of benign cysts.
What about chemotherapy?
With chemo, the damage really depends on the specific drug alkylating agents are by far the most toxic, as well as the patient's age and the total dose. But here, the pre-treatment AMH level has proven to be a fantastic prognostic tool.
So it can help predict who is likely to recover ovarian function after cancer treatment.
Yes, it's a very strong predictor of long-term recovery.
So bringing all this together, the biology, the testing, it's all pointing towards one thing, isn't it? The need for individualized treatment.
Absolutely. The data mandates it. Major guidelines from ESHRE and ICE all strongly recommend using age combined with AMH or AFC to create individualized stimulation protocols for IVF. It's how you maximize success while minimizing risk.
So to synthesize all of this, what are the key takeaways?
I think the biggest one is that AMH and age are the current gold standards for planning art. We have to accept that a one-size-fits-all protocol is just not good enough. Individualized evidence-based strategies are absolutely essential for good patient outcomes.
So what does this all mean then for the long-term health of our patients? We've talked about how diminished ovarian reserve is linked to an increased risk of early menopause and all the long-term health risks that come with that skeletal cardiovascular.
Right.
So here's a thought for you to reflect on. Given that connection, how should clinicians structure the follow-up care for a young woman who is diagnosed with DOR, even if she goes on to have a successful pregnancy? That's where this academic knowledge meets lifelong patient care. Now, to reinforce what we've covered, here's a specific review exercise for you. A 36-year-old woman is undergoing IVF. She has an AMH result of 0.8 nanograms per milliliter and an AFC of 6. Based on the Bologna consensus we discussed, how would you classify her ovarian reserve status? And what's the primary factor, her age or R markers? That is the strongest predictor of her chance of achieving a live birth. Think about that distinction between quantity and quality. She clearly meets the criteria for diminished ovarian reserve. That suggests a reduced quantity of eggs and likely a reduced response to stimulation.
But her age, 36, is still the strongest single predictor of oocyte quality, and therefore it's the strongest predictor of her ultimate chance of achieving a live birth. Quantity and quality are not the same thing.
Join us next time for another deep dive.